Welcome to Infection Prevention and Control in Schools. My name is Nurse Kevin. I'm a school nurse of about 6 years, and I'm a registered nurse, gracious, since 1998, quite a few years. Presenting this, what I'm looking at is trying to present a school-wide, disease vector-wide type of presentation. I know right now we're facing a crisis with COVID-19, but we also have other things on their way. We have the flu. Of course, flu season's about to kick into gear, high speed. We got measles, we got rubella, we got pertussis. We got all kinds of things going around in school, everything including head lice. But we're not going to talk about head lice in this presentation. We're going to fix our attention on infection prevention in a broad sense with a little bit of COVID undertone. And you'll see what I'm doing and talking about here as we progress through the presentation. Infection prevention and control in schools. Here's where we are last year. Last year, first day of school, kids walking all down the halls, having a good time, meeting each other. This year, a little bit different. We don't have any children in the school up until a few days ago. And then the children come back covered with masks. I don't know if your school district has children wearing their masks, teachers wearing their masks, but our school district is. And we have our 6-foot restriction. We want to physically be apart, physically distance, if you will. And we'll talk about that a little bit. Maybe you've heard of social distancing. And we need to say, Bobby, stand back 6 feet. Susie, 6 feet. Little Timmy, little Julie, 6 feet. But we end up right back where we started. The hallways are just not designed to be socially or physically distanced. Kids are everywhere running up down the halls. Even with a modified schedule, even with hybrid schedules, if you've heard that term before, kids are still on top of each other. We can try our best to put a bubble around these children, but the virus is going to get in sooner or later. Something is going to get in. We try to bubbleize these children, if that's a word, during flu season, but you can see that each and every year we have children come down with influenza A, influenza B. Learning objectives. Apply effective infection prevention practices in school setting. Maintain a clean environment, safe and conducive to learning. Contain infective organisms spread leading to the infection exposure. Maximize cooperation from students and our interdisciplinary team to prevent infection transmission. A lot of big words there. Each year in school, 40% of children miss at least 3 days due to sickness, due to an infection. 22 million school days are lost each year to the common cold. 38 million school days are lost due to influenza. How many days will be missed because of COVID-19? Have you ever heard of the chain of infection? I like to ride bicycles, and so I've kind of adapted this little bicycle chain here. We're going to start right here. Chain of infection begins with you, me, students, visitors, anyone coming into our buildings. It's the next sick person, the susceptible host. Like I said, you, me, students, visitors, anyone inside the schoolhouse. You got to have the agent. That's the actual germ that's going to end up causing infection. Bacteria, viruses, fungi, parasites. Hopefully we won't see any parasites in our schools. Where the germs live, the reservoir. Now, I'm using zombies here, and I know a lot of people probably don't like that, but we tend to see other people as not being clean compared to us. And the article I put out when I'm giving away this PowerPoint kind of describes that a little bit. Would you rather eat your lunch using your hands or have someone else feed it to you with their hands? A lot of different analogies I could use there, but you get the point. Germs live on people, food, animals, soil, water, zombies. The germs escape. This is the portal of exit. At what bodily orifice, if you will, do the bugs or the germs escape from? And it's not always an orifice. It could be coming off your hair, coming off your skin, coming out of your eyes. It could be all kinds of different ways that the portal of exit is achieved. Germs get around the mode of transmission by touching stuff, surfaces, hands, droplets of spittle. And we're going to talk about that a little more in just a minute. And then eventually germs get into you, the portal of entry. How do the germs get inside you, and how do they make you sick? Germs can get into you in many ways. How about fiddling with your mask, touching your face, touching the skin, picking your nose, rubbing your eyes, eating, toileting, and even eating while toileting. And that's how you get sick. Not necessarily eating while you're toileting. There's a whole lot of different ways that we can get sick, and it's usually from something that we've actually contaminated ourselves with. Yes, we can get sick if someone sneezes or coughs in our direction, but a lot of times I think it comes off our hands, and that's Nurse Kevin's opinion. A lot of times it comes off our hands, and we tend to put it in one of our bodily orifices and inoculate ourselves with the illness. So we start with the susceptible host. That's you, me, and them. We have to have the agent, the germ. Next is the reservoir, where germs live. The portal of exit, how the germs get out. Mode of transmission, how germs spread around. And the portal of entry, how the germs get into you and make you sick. That is the chain of infection. But what is a germ? Now, we nurses know what germs are, but not everybody knows what a germ is. Everybody has an opinion about a germ. Maybe it's a bacteria. Sure, bacteria can be a germ, but we have bacteria in our yogurt. We like to eat that. We have bacteria in our stomach where it belongs. Doesn't make us sick there, but if it gets in other places, it very well may be. A microorganism that causes disease. Basically, a germ is something that makes us sick. We have bacteria, pneumonia, meningitis, food poisoning. We have fungi, fungus, yeast. Fungal infections include Candidus, autobrewery syndrome. Do you know what autobrewery syndrome is? Look that one up. That's a good one. Protozoa. These are little advanced bugs, if you will. Protozoa. It's strange because protozoa can even live on human beings. Malaria, Giardia, Trichomonas. Viruses. Viruses cause diseases such as the flu, common cold, and COVID-19. Did you know there are more microscopic bugs living on your body than there are people on the whole earth? Gross! Did you know that the ground we are standing on is made of living tissue? Gross! How do we break the chain of infection? And that's ultimately what we're trying to do. I mean, when we look at masks, when we look at gloves, when we look at isolation, when we look at quarantine, we're trying to break the chain of infection. We all start with a susceptible host. Like I said, it's you, me, them. It all starts with us doing our daily thing, doing the day-to-day. Germs are everywhere. We know that. Germs, good or bad, if you want to call germs good, microbes rather, are everywhere and on everything and on people. Not you, but folks I know. Which brings us to the reservoir. This is where germs live. And no, germs just don't live on zombies or other people. Germs live on dogs. They live in the dirt. They even live on our food that we're about to eat tonight. Then you got to have the portal of exit. This is how germs get out and create new reservoirs. Not every single germ that gets out of the reservoir actually goes into someone right away. Sometimes the germs, the portal of exit, they come out of the reservoir and they create new reservoirs, and we'll talk about that. So potty. We can generally consider the commode a dirty place. The bathroom is usually a place where we consider it to not be clean. No matter how often we clean it, it's usually the dirty place, especially a school bathroom, Walmart bathroom, Fred Meyer's bathroom, Safeway bathroom, wherever bathroom you are, gas station, public, we consider it to be dirty. I've kind of hit home on that one. The portal of exit, how germs get out and create new reservoirs. So here we have first, we have the child, reservoir. Germs get out, and we have a new reservoir. But he's touching stuff. These poor little children touch every which way can loose, but they tend to make new reservoirs. We do it as an adult. We end up making new reservoirs as we move about our day-to-day. The portal of exit is the means by which the germ can escape from the reservoir. The portal of exit, how germs get out, but the portal of exit is the means by which the germ can escape. We see here, gets on his hands. We see here, gets on the potty. Germs, they're everywhere. Everything that we touch creates germs. Let's back up real quick, and we'll see that we know that that child that was in there most likely touched the lid to lift it, drop it, as he sat there on the toilet front and back, and as he flushed it there at the handle. Basically, he was the reservoir, and the germs are now on the new reservoir. This is the reservoir, but the chain is not complete. Even though we have a new reservoir, the chain is not complete at this point. There's no susceptible host. The toilet itself cannot get sick. Paradoxically, the hands are the portal of exit in this situation. See, we were thinking that we have to spew things out of our bodies in order for that to be the portal of exit, but not always. Remember, the reservoir doesn't do anything. It doesn't breathe. It doesn't move around the toilet there. It doesn't really do anything at all. The hands are the actual motion, kind of like when we sneeze. We are now the reservoir. We sneeze out, and the viruses, germs, or whatever we're sneezing out of us is the portal of exit, the way they get out. In this situation, the hands are the portal of exit. So we have our germs here, and now we make a new reservoir here, and then we flush, and now we have gotten the germs, the portal of exit, through the hand onto us. Now, we're still not done. See, the hand itself has got the germs on it, but it really doesn't do anything. Unless you've got a cut or something on your finger, the germs really aren't going to do much. They're going to sit there until the next time we wash our hands or until we put them in our mouth. Mode of transmission. It's not the dirty commode, the hand, or the person. It is the method by which the germs move or spread from one place to another. When this child touches his face, he gets the germ within him. Washing hands breaks the chain at the mode of transmission by blocking the portal of entry. Look at that dude. Down the hatch he goes. Smack. We've broken the chain. Now, we talk about hand washing in this presentation a little bit later, and it seems almost redundant to talk about hand washing again, but hand washing is the single most important thing we can do to break the chain. Where do masks come in? Everybody's wearing a mask now with the COVID-19. Pretty much every municipality throughout the entire country are wearing masks or requiring masks. And where do they fit in into the chain? So we have our next sick person, the susceptible host, you, me, students, visitors, anyone. We have our cooties, the germs, the agents, bacteria, viruses, fungi, parasites. We're interested in our viruses right now. We have our reservoir where these viruses are living. And here we go, our nice, beautiful reservoir. Remember, the next link in the chain of infection is the portal of exit, how the germs actually get out. There he is. Cough, sneeze, talk, laugh, just doing day-to-day things with his mouth. And we do a lot of things with their mouth. I'm talking with mine right now. Remember, the next link in the chain of infection is the portal of exit, how the germs get out. The portal of exit in this situation is spittle, sneezing, coughing, talking. The germs, the reservoir, the portal of exit. Germs come out of the reservoir. The mode of transmission is the droplet, and the mask breaks the portal of exit. What if we put a mask on the reservoir? We've broken the chain of infection at that point. Now, big question. What about the mask? What about the mask? We've blocked the chain. We've broken the chain of infection. But now the mask is the new reservoir. It's covered with whatever we were attempting to keep off of others or to keep others off of us. The mask blocked the portal of exit. Now the mask becomes the reservoir. Simply like the child sitting on the toilet creates a new reservoir. The child is the reservoir. Now the toilet is a reservoir. The person with COVID-19 or with a virus like the flu or cold, they were the reservoir. Now the mask is a reservoir. So you can see here, germs get into you through the portal of entry by fiddling with your mask, touching your face, cuts on skin, picking your nose, rubbing your eyes, eating, toileting, and of course, eating while toileting. This is how the germs get into you and make you sick. As a school nurse, we suggest staying home for illnesses such as the flu, measles, frequent diarrhea, hand, foot, and mouth disease, a rash from unknown origin, fever from unknown cause, COVID-19, and hey, a bunch of other stuff. COVID-19 specifically Now, I know that this is big news for everyone, that COVID-19, we need to send people home, and we're going to get into that real quick about isolation. We're going to get into quarantine and some other big topics about COVID-19. What happens in this situation, if we can break the chain of infection by the exclusion of the reservoir, the person who is sick or suspected, if you will, to be sick with COVID-19 for a specific period of time, then maybe we can break the chain of infection. Even if the person is showing no symptoms, we may need to take measures to address breaking the chain. These are the faces of the reservoir. Now, what we're going to talk about is the natural history of disease, a timeline. And this will come together as we progress through the presentation, because understanding this stage, and these stages rather, helps you better understand on how the illness will spread, especially from someone who's asymptomatic. We all start at the stage of susceptibility, and then we have a moment of exposure. Doesn't mean we're sick yet, but we have exposure. Later, we have the onset of symptoms. It takes time for the bug or the germ, the agent, to manifest itself and cause us to become ill. So we move from stage of susceptibility to stage of subclinical disease, and then finally, we have an onset of symptoms where we actually start showing symptoms. Then, after a period of time, because we don't rush to the doctor when we sneeze, we don't rush to the doctor when we get a sore throat. It's when we've been sick for a day or two, or we're really starting to show symptoms right off the bat. Then we go to the doctor, and then we get the diagnosis. We're already in the stage of clinical disease. We're already shedding virus. We're already shedding agent, and we're sick. Measles, you're contagious about 4 days before the rash. Influenza, seasonal flu, you're passing that particular virus on pretty much at the onset of symptoms. Now, it seems like, okay, I've got symptoms, I need to stay home. I got symptoms, I don't need to go to work. But what is a symptom of influenza? What's an early symptom? Sore throat, cough, a sneeze? It's very innocent, very easy to misassociate with just not feeling very well today. And we do have those off days with our health periodically. Doesn't mean that we jump from, I sneezed and therefore I've got the flu. But still, someone early on could sneeze and spread the flu very easily from the first day that they're infected with or actually presenting with influenza. Chickenpox, 5 days before the rash shows, you're contagious. Fifth disease, 7 days before the rash. And my understanding is with fifth disease, by the time the rash pops out, you're really not contagious anymore. COVID-19 is 2 to 3 days, with 2 being pretty much universally accepted days before symptoms. So you are shedding virus if you have COVID-19 and potentially making other people sick 2 days before you actually began showing symptoms. What we're going to talk about here with COVID-19 is quarantine versus isolation. This at first was hard for me to kind of grasp. I was having a hard time understanding this because it seems to me that quarantine and isolation, same thing. But the CDC refers to it as being different. Quarantine, think of quarantine, which keeps someone who was in close contact with someone who has COVID-19 away from others. We're going to talk about close contact in just a little bit. Isolation keeps someone who's sick or has already tested positive for COVID-19 without symptoms away from others, even in their own home. So quarantine, if you've had close contact with a person with COVID-19. Isolation, if you are sick and think you know you have COVID-19. We're going to look at quarantine being stay home until 14 days after your last contact with someone who's had COVID-19. 14 days. Isolation, if you are sick and think or know you have COVID-19, stay home until after at least 10 days since symptoms first appeared and, keyword, and, then at least 24 hours with no fever, without fever-reducing medications, and then when symptoms have improved. So there's 3 requirements there. I've had people say, well, if I stay home 10 days, I can come back to school. No, you had a fever yesterday. Stay home another day. Well, I feel good, but I don't feel as good as I need to. It's been 10 days and I don't have a fever, but I still feel like, I feel like poop. Well, stay home. So we would treat it like anything else. 10 days is just a guideline. 10 days. Now, if you look at quarantine, if you look at the Q, quarter, See, there's a 4 in 14. Maybe that helps you understand. Quarter, 4, maybe. I know that's a loose association, but it's association nonetheless. Isolation, I, 10, 1, isolation, 10 days. Maybe that'll help you remember. During the quarantine, the 14-day quarantine period, check your temperature twice a day and watch for symptoms of COVID. You're home for 2 weeks, so basically check your temperature twice a day and watch to see if you have any symptoms of COVID. Isolate at home for at least 10 days if you have tested positive for COVID-19 but do not have symptoms. So you've got a positive test, stay home for 10 days, and stay home for 10 days from the time that you had the sample taken. On quarantine, you would stay away from people who are higher risk for getting very sick from COVID-19, your high-risk population. Under isolation, if you live with others, stay in a specific sick room or an area away from other people or animals, including pets. Use separate bathroom if available. Now, I say pets. Pets can't get sick with COVID-19, but they're able to carry it around. So, and pets love to be petted. So if your dog goes from one room in the isolation and walks over to someone else and someone pets the animal, yes, it's not close contact, but consider that there may be COVID-19 on the animal. Remember the new reservoir, and then the new person, the susceptible host, touches and then becomes sick with COVID-19. Now, I kind of put these up. I hate big, wordy slides, but I've put in these 2 slides up in the presentation, and I asked, do you have any questions about this particular concept, quarantine versus isolation? Remember, quarantine 14 days and isolation 10. Now, we're going to define close contact. Close contact is someone who was within 6 feet of an infected person for at least 15 minutes starting from 2 days before the other person's illness symptoms began. Contact with an asymptomatic person 2 days prior to their positive specimen being collected until the time the person's isolation time is passed, 10 days. Remember, isolation 10 days, quarantine 14 days. Oh my gracious. There's Karen. Put your mask on. There you go. And we'll play with Karen a little bit more. I'm going to back up and cover these concepts a little closer. Let's just back the slides up here. Close contact. Someone who was within 6 feet of an infected person, mask or no mask, for at least 15 minutes, and we consider 15 minutes cumulative over a 24-hour period, starting from 2 days before the other person's illness symptoms began. Now, I've had people get a little bit nervous about the 15-minute deal. They've mentioned to me that 15 minutes, so the virus doesn't get on me until 16 minutes, kind of like the 3-second rule, the 5-second rule when some piece of candy or cookie hits the floor. It's not really that. What I want you to do is think of the person with COVID-19 as the faucet in the sink, and you are a gallon milk jug that you're trying not to fill up, if you will. So it takes time for the water coming from the reservoir to fill the bucket, the new susceptible host. I need you to keep that in mind. It's a real hard concept to grasp hold of. The coronavirus does not wait for 15 minutes before it infects someone. But at 15 minutes, you have filled your bucket up, and the amount of shedding the other person has done of the virus may be enough time to bombard your own health defenses to where you now are more likely to become ill because you've had enough time, enough of the spittle has made it in your general direction. You've consumed enough of it, which is pretty much disgusting. But that's the concept. It takes time to fill that bucket up. Now, if you spend 7.5 minutes with someone, your bucket's half full. You go back to that child, that student, that person, spend another 7.5 minutes. In theory, you've spent 15 minutes with them through the course of a 24-hour period. And yes, now you're considered to have been in close contact. You can be in close contact with an asymptomatic person. So we know that a person is close contact with an asymptomatic person because the person had a test. So if they've had a positive specimen, so what you want to do is if a person had a positive specimen collected on Wednesday and they found their results out on Thursday, then you go back 2 days before Wednesday when their positive specimen was collected to Monday. And you wait, the close contact, you wait until the time of the person's isolation time is past 10 days. So if the person knew they had a positive test and they're in their isolation period, or they knew they had coronavirus or the corona-like symptoms, and they're on their 9th day, and you meet that person and you are now with them for 15 minutes or longer in a 24-hour period, you are now still in close contact, regardless of the person's current condition. They may be feeling great. There's Karen. Close contact in this situation makes a lot of sense if you provide care at home with someone who is sick with COVID-19. You're going to be with them quite often. Close contact, shared eating or drinking utensils with someone who's had COVID-19. And these children definitely don't drink after each other, right? I've even known some of the children to trade bubble gum. Close contact with a person, you got some spittle on them who's got COVID-19. So if you're sitting there talking to them and, oh, goodness forbid, we have had this happen at some point in our life where someone or us has accidentally spat while we were talking. It's a terribly gross thing and it's very embarrassing, but now we've got to consider talking with someone with COVID-19, 15 minutes or no 15 minutes. If you get their spittle in your mouth, you need to consider yourself close contact. We're going to reiterate this. A person should stay home, self-quarantine for 14 days after their last close contact with someone with COVID-19. Even if you test negative for COVID-19, you need to quarantine. Remember the contagious period. This was a little bit of a difficult concept, but we've had some false positive, we've had some false negatives, and my understanding is to be safe, if you have had close contact with someone and you want to expedite the quarantine process and thinking that if I go get a test and I come back negative, I can go right back to work, I feel great. That's not the case. You'll still need to quarantine if you've had close contact, even with a negative COVID test. Now, positive COVID test results. What do we do? If you're a district employee, Human Resource will take it from here. Yes, I love taking care of teachers. I love taking care of the faculty and the staff, but the district employee goes to Human Resources. If a student has a positive test, the nurse will perform a bit of contact tracing. The staff member is notified by a parent or guardian that a student has tested positive for COVID. What does that staff member need to do? Needs to maintain student confidentiality. Very important. Some of these students will get on their Facebook, Instagram, whatever social media that they're on, and they will brag about having COVID-19. For whatever reason, they feel like they need to let everyone know. But some kids, they're not so happy with it. Some parents, more so, not very happy with everybody knowing either. Staff members are then to defer to the nurse or designee. So basically, if you're told by a parent or guardian that there's a student that has tested positive for COVID, then I need to find out, or the nurse needs to find out. We're going to talk a little bit about symptoms of COVID. Oh my gracious, there's Karen. Get your mask on, guys. There you go. Emergency warning signs for COVID-19. Of course, trouble breathing. We're going to go see the nurse. Persistent chest pain or chest pressure. New confusion. Inability to wake up. Of course. If you can't wake a child up, they need to see the nurse. Bluish lips or skin. Do you have any questions about this? Trouble breathing, chest pain, confusion, lethargy, cyanosis. What we're doing here, this is common sense. It doesn't matter COVID or no COVID. If you see these symptoms of COVID-19, these severe emergency warning signs for COVID-19, you're going to send them down to the nurse or call 911 anyways. You're a parent. I like to remind my teachers they are parents. They are teachers if you're not a parent. Teachers work with children. They know what sickness looks like. These symptoms, you'd call 911 or send them down to the nurse anyways. That's a no-brainer. What findings would result in exclusion from school? Some symptoms of COVID-19 we may not initially think that we need to exclude, but we do. If a child presents with new onset of cough or shortness of breath, I mean, we're talking brand new. We're not talking about an asthmatic. We're not talking about a child that comes in from outside, been playing real hard, got himself choked up a little bit. The coughing will probably resolve. When in doubt, send them down to the nurse or have the nurse come down. But if we're looking at a reason, Occam's razor, simplest explanation, I'm not going to just jump to COVID-19 for a coughing child. Shortness of breath. Do they have asthma? Have they been out running at recess, or have they been out running during sports or PE? So I want to look at all the findings and kind of bring that together, but I don't want to just disregard the possibility of COVID-19. And then we look at two of these following. So consider the one, of course, being one. That's a one and done. But what if they've got a temperature of 100.4? Okay, that's concerning in and of itself. Who knows why their temperature's up? Are they bundled? Have they been out exercising? What about muscle pain? Possibly. Those two together, they got to go. Sore throat, chills, got to go. GI issues, loss of taste or smell, got to go. And you got to look at your common sense. I mean, if we've got 100.4, really, that's not okay. I mean, there's something going on there, and we need to figure out why 104, just by itself. Not necessarily that we need any of the other symptoms. I'm concerned about that 100.4. I want to find out what's going on. Loss of taste or smell. Things just don't taste right. Something's wrong there. That's one of those symptoms that have come up over and over with people who are infected with COVID-19. It's worth a little more looking. Chills, GI issues. If you see two of these symptoms or more, you need to kind of pay real close attention to the possibility of this child demonstrating symptoms of COVID-19. At this point, the child is sent home and testing is encouraged. The child will stay home until the test results are received. We don't know what the child has these symptoms for. It could be for something else. We'll talk about that in a minute. But right now, we don't know, and we're trying to avoid, we're excluding the reservoir. We're breaking the chain at this point, the possible chain. If COVID test results come back negative and the condition that caused the COVID-like symptoms have resolved, the child can return to school. Well, of course, unless they've had close contact, then we need to look at keeping them home, 14 days quarantine. If the test results are positive, the child will stay home until the three magics. The child feels better, and 10 days have passed since the symptoms have started, and 24 hours since last fever without fever-reducing medications or measures. Then the child can return to school. If the test results are positive and there were no symptoms, asymptomatic, they went to get tested, hey, what do you know, you're positive, but I don't feel sick, okay? Then the child stays home until 10 days have passed since testing. So since the child received or actually gave the sample, when the sample was taken, that's when the 10 days starts. If the test results are positive and there were no symptoms, but symptoms developed during the isolation period, the child stays home until the child feels better, 10 days since symptoms have started and 24 hours since the last fever. So we start all over from scratch. What if the child shows symptoms but does not get tested? This is a difficult one because parents really don't want, some parents anyways, don't want to get their child tested. The child stays home for 10 days since he first showed symptoms. He can return to school when the child feels better, 10 days have passed since symptoms started, 24 hours since last fever. And the condition that caused the COVID-like symptoms have resolved. Because if symptoms are noted, it may only be an illness and not COVID-19. But we still have to take it at face value. We've got symptoms that look COVID-like. We need to follow through with the isolation and quarantine process if they don't want to get tested or they don't want to be diagnosed. They may not want to go into the doctor's office, period, for whatever reason, because it may be strep throat, maybe flu, maybe something different. But even with strep throat, flu, cold, we still need to look at keeping them home. And this is why, if we look on the far left, symptoms of COVID-19, very, very similar to the far right, the flu, somewhat similar to the cold, and very similar to the strep throat. So you can see here that a lot of these symptoms, and you're not going to see all these symptoms of COVID-19. If we got fever, sore throat, GI issues, and aches, we might say they've got strep throat, but we really can't diagnose. We have to have that test, or we have to have the doctor diagnose and say, what do you know? We've got strep throat, and then we can follow our school's protocols in order to keep that child excluded, because remember, strep throat we can spread it. The cold, we can spread it. And flu, we can spread it. Daily screening. What you need to do is to take a visual screening of the students each morning. This is something for the teachers to do. And you remember when I talked about teachers being parents and teachers being teachers. They've taken care of children, and they will send children down to the nurse. I've had teachers tell me, I'm not a nurse, how do I know? Send them down for the same reasons that you sent them down last year before COVID-19. The same symptoms that you see for cold, flu, strep throat, they would need to come see me. Gut instincts, persistent cough, hot flush face, watery or glazed over eyes, looks tired, complains of feeling cold or chilled, frequent trips to the bathroom, they may have diarrhea, vomiting and nausea, and they're not their normal selves. Teachers know these children better than us school nurses do. Parents know them even more. Teachers see these children in and out each day, and they know when they're not their normal selves. This is a form that we're filling out each day, looking for this visual check, and this may be a form that you'd like to incorporate in your day-to-day. And in this situation, what you would end up doing is during my morning roll call, I completed the visual screen of each student, preloaded the kids into this handy table. When you submit the attendance email to this person and to that person, whoever is, designated for that, to notify them that there were no kids showing symptoms or the names of students you were concerned about. Either the school nurse or the assigned will call these children down for an additional screening and notify you when to send each student. What we don't want to do is send all the children every morning who have COVID-like symptoms and bombard the office. Because if we've got one kid who actually does have COVID, we don't want close contact situations for all these children who are just showing symptoms of this and that. What to do if you test positive for COVID, you're being tested and are waiting for results, you are sick, had close contact with someone who has had COVID. Not trying to beat a dead horse, just want to reiterate a few things to make sure we understand. First, staff and students, stay home if you are sick, please. We know that. If you're sick, don't be tough. Go on, stay home, get your sick day in. Staff, if you are being tested for COVID-19 and are awaiting results, do not come to school. You should quarantine, isolate at home, depending on if you were close contact or if you're actually showing symptoms, and arrange for a substitute as needed. So if you're going just for a look-see, I don't know why you'd want to do that, just because you want to see. Because remember, if you've been in close contact with someone and your COVID-19 test is negative, you still have to quarantine at home. So I don't see the reason for it. If you want to go for a look-see, that's totally up to you. But you should stay home because something's telling you that you may be positive. So stay home and wait for results. Do not come to school. Staff, if you are positive for COVID-19, call Human Resources and ask for an HR generalist. You want to call your Human Resources department and say, hey, listen, I went down and got tested and I nailed it. I'm positive. If you are notified that you've had close contact with someone who's had COVID-19, stay home and call Human Resources and ask for an HR generalist. What I mean by that is you get a call from the local health department. They probably don't give you the name, but they want to say your name came up with a person who feels that you've had close contact with them. So now your next step is to call Human Resources and say, hey, I've been around someone for 15 minutes or longer and within 6 feet, and now I've been deemed close contact. If they are tested for COVID-19, they should quarantine and isolate at home while awaiting the results and notify the school nurse. This is for the student. If they are tested for COVID-19, they should quarantine and isolate at home while awaiting results and notify the school nurse. The student tests positive for COVID-19. The family should notify the nurse. If you, the staff member, are notified, please keep and maintain confidentiality and notify the nurse or other person as assigned. If a student had close contact with someone who's positive, the family needs to notify the school nurse. Now, we've talked about a lot of things. We've talked about close contact. We talked about quarantine. We talked about isolation. We talked about the chain of infection. And no infection control program would be finished without a good handy-dandy wash your hands presentation. Now, this seems so redundant, but we have complacency in our lives. Even school nurses get complacent. Maybe not so much with washing hands, but we get complacent with a lot of things. Just today, I was watching someone with their gloved hands touch their mask and then put their hair behind their ear. We got gloves on. We might as well just use our bare hands if we're going to use our gloved hands like our bare hands. Remember, susceptible host. Germs can spread from person to person or from surface to person in some of the following ways. You touch your eyes, nose, mouth, or other bodily orifices with your hands. You blow your nose, cough, or sneeze into your hands. Touch contaminated surfaces with your hands, or you prepare or eat food and drinks with your hands. These are ways that we take our hands and we make ourselves ill. If soap and water are not available, use hand sanitizer, 60% alcohol. At the beginning of each school day, before and after breaks, before putting on, touching, or removing facial coverings, after coughing, sneezing, or using a tissue, before and after eating, before and after using the bathroom, touching the trash or frequently touched surfaces, door handles, light switches, sink handles, before, during, and after preparing food. This kind of stumped me at first. Why would we wash our hands during food preparation? But, the other day I'm making a salad that I'm also working with some raw chicken. I go back and forth, so wash your hands. After doing something gross and when they just look dirty. Now, the thing is, we look at like the fourth one down after coughing, sneezing, or using a tissue. I'm going to give you an idea. I want to plant in your mind an idea here. Which is more dirty, if you will? Someone's hands after they've blown their nose or sneezed with their nasal mucosa now being contaminated onto their hands, or after going to the bathroom and not washing their hands. So you blow your nose with your hand, even using a tissue, or you go to the bathroom, and in neither situation do you have the person wash their hands. Whose hands are going to be more dirty? I would think that the nasal mucosa is carrying more cooties, if you will, than our urine. Now, fecal matter, different story, but urine, what we do most of the day when we're going to the bathroom, is generally considered to be clean. Now, they're saying that urine now has, things in it that's not sterile, because as soon as it leaves the body, it's picking up cooties. But consider urine over nasal mucosa, which is dirtier. Who knows? Maybe it depends on the reservoir. I don't know. Just an idea. 5 steps to wash your hands the right way. Straight from the CDC. First step, wet your hands. Best thing to do is get your hands all nice and wet. Apply soap. Scrub for at least 20 seconds. And there's plenty of videos on the internet showing you how to scrub your hands for 20 seconds. You rinse your hands, making sure you get all the soap off. Water not too cold, water not too hot. If the water's too hot, next thing you know, you're removing the oils from your skin, all the oil, and you're drying your skin out, causing cracks and other issues later. Dry your hands. But don't throw that paper towel away. You'll need that to turn off the water. You'll need that to open the door. Hand sanitizer. Soap and water are the best. Make sure it is a minimum of 60% alcohol. Hand sanitizers can quickly reduce the number of germs on the hands, but may not get rid of all germs. I thought that's what sanitizer meant, but we take it at face value. It may not get rid of all the germs. Will not remove visible dirts and grease. May not remove harmful chemicals from your hands. Steps to use hand sanitizer the right way. Dispense the right amount into the palm of one hand. Rub your hands together to apply the sanitizer to both hands. And rub for at least 20 seconds until your hands become dry. The stuff's gooey, 60% alcohol, so it doesn't evaporate in an instant. 100% alcohol would just dissipate into the air quickly. So 60% or higher, 20 seconds, and you're good to go. Give example. Cover coughs and sneeze to help reduce the spread of germs. Cover your mouth and nose with a tissue and then throw it away. Then wash your hands. No tissue, use your elbow. Don't sneeze or cough into your hands. Wash your hands after you blow your nose, sneeze, or cough. And remember, we talked about sneezing and coughing with the nasal mucosa being probably, and I'm guessing here, probably dirtier than urine. And we see the word social distancing. Do children actually understand what social distance mean? Do they have any confusion over that? Being that we're all alone in this clearly misunderstood struggle, I will definitely maybe be wearing my mask so I don't fall into ill health from meeting someone in poor health. But wait a minute, isn't that the same difference? Well, that's my unbiased opinion. And on all this old news, why can't we just socially distance? Oh, good grief. Socially distance. Social. Needing companionship and therefore suited to living in communities. Distancing. Making someone or something far off or remote in position or nature. Hey, fat-free cream, right? Let's look at physical distancing. That's what I like to call it. The kids seem to understand it. I know it seems like tomato, envelope, but I don't know. I like physical distancing. Not really, not the nature of physical distancing. I wish we can all just get over this and go back to being humans. But physical distancing, COVID-19 spread through respiratory droplets. We talked about this earlier. A person's droplets are spread when you cough, sneeze, talk, sing, shout, laugh, whatever. Next thing you know, there's Billy, very upset, Susie, very embarrassed. When close contact, these droplets can land into your nose, mouth, or even inhaled into your lungs directly. Physical distancing. You know, not everybody can throw a football the same distance, but physical distancing helps reduce the distance by which the spittle makes it, and of course, everybody's happy. Practicing physical distancing, it may slow the spread of the virus, 6 feet. Since people without symptoms prior to showing any symptoms may play a part in the spread, keeping your distance protects you and protects the other person. Physical distances is especially important for people who are at higher risk for severe illness from COVID-19. Mask. As a Twitterer, if you want to call Twitterer, I just removed my mask and sneezed into my sleeve. Am I doing this right? Absolutely. There's Karen. Get your mask on, guys. There you go. Yes, sneezing into your sleeve or tissue is preferred. If you do have one that just cuts loose in your mask, change your mask. Masks, when worn properly, have been shown to reduce the spray of respiratory droplets. When used widely in public settings, masks are most likely to reduce the spread, and mask wearing alone may not prevent the wearer from the virus. Hence, proper wearing of face masks along with good hand hygiene and physical distances is the best defense. The CDC made an announcement that smoke inhalation, the mask won't protect you. We have a lot of wildfires out here in the Pacific Northwest right now this year, and they've made a declaration saying that the mask to protect us from COVID-19 will not protect us from smoke particles, which are bigger than the virus particles. Now, with that being said, I'm not trying to be condescending or trying to be obstinate. What I am saying is the mask actually blocked the spittle from which this virus is piggybacking. If a virus alone, airborne, whatnot, not to say that COVID-19 is airborne, I don't know. That's not been studied or learned yet. We don't know if it's airborne. We assume right now that it is not. So we'll stop talking about that because we're speculating. But the masks in and of themselves help capture the spittle as we talk and blocks the spittle as others talk. The spittle is by which the virus is piggybacking or riding on. Who should not wear a mask? Children under the age of 2. 2 years old, good. 1-year-old, not. Babies, no. They can't tell you that they're short of breath, that their airways being occluded. Anyone with medically diagnosed breathing problems and a 504 or IEP documentation in place. Face mask maybe, or a face shield might work in these situations. Some children they're just not going to wear them. It's not about being obstinate. They may just have an emotional issue that just prevents them from being able to tolerate the mask. Anyone able to remove the mask without assistance, students who are nonverbal. If a student can't tell you that he's short of breath, then just leave the mask off the student. Masks rather. From now on, I'm going to wear a mask in grocery stores. I prefer a disguise when purchasing obscene amounts of junk food. Now, you've seen these three walking around with a mask under their chin as they talk and carry on. You've seen them hanging off their ear, and maybe you've seen them on top of their eye. I don't know. There's Karen. She's cleaning things up. Get your masks off, guys, and get them on right. There you go. Wear a mask properly. This is how you wear a mask properly. And you see people pull them out of their pockets, put them on their face, take them off, put them back in their pocket, purse, hang them from their rearview mirror. I don't know why anyone would want to hang a mask from a rearview mirror, no offense. Wash your hands before putting on your mask. You may have COVID on your hands. Remember, you're putting something over your airway, over your facial orifice. If you have COVID-19 on your hands, you put your mask on, you're just created a reservoir, and that mask is covered in COVID, in theory. Consider the inside of the mask and the outside of the mask. There is a difference. Usually on a surgical mask, the outside is green or blue, and the inside is white. Someone walked in the school the other day with the outside face or the inside of the mask facing out because the green color did not match her outfit. Put it over your nose and mouth and secure it under your chin. Put it over your schnoz. You've seen those people, yes. Put it over your nose and mouth and secure it under your chin. Try to fit it snugly against the sides of your face. Remember, we have clean hands, clean masks, and we're fitting our mask to our face. Make sure you can breathe easily. Some of these masks are thick. Some of them have extra layers in there because some people have actually put layers to help them with protection from the smoke particles. That's going to reduce the airflow even more. Wash your hands after putting on your mask. Wash your hands after touching your mask. To remove a mask, untie the strings behind your head or stretch the ear loops. Don't touch the front of the mask. In theory, the front of the mask has caught COVID-19 and is now a reservoir. Don't touch it. Fold the outside corners together and place the mask in a washing machine or dispose of a single-wear mask. If it's cloth, wash it in a washing machine, provided that the fabric will allow you to do that. Be careful not to touch your eyes, nose, mouth when removing, and wash your hands. Remember, you took the mask off. The mask is the new reservoir. We wash our hands so we don't create the reservoir in our hands and then move them into our bodily orifices. Washing a mask properly. Masks should be washed regularly. Wash in the washing machine using the regular laundry detergent and the warmest water setting for the cloth used to make the mask. Dry on the highest heat setting and leaving the dryer until completely dry. If air dry, lay flat and allow to completely dry. If possible, place the mask in direct sunlight. You know, if you wear a mask all day, if you put it in the dashboard of your car during the heat of the day, you should be fine. But we're starting to cool down in many parts of the country. I say wear a mask that can be washed if you're going to wear one. But if you can't, put it in the dryer, and still even then, let it dry for a few days and then use that mask again. I'm seeing a lot of people with an inventory of masks. I wonder what we're going to do when this is all over with all these masks. We're going to talk a little bit about universal precautions. In 1983, Centers for Disease Control, CDC, published the guidelines for isolation precautions. This is the baby, the seed that planted universal precautions and later standard precautions, which we'll talk about. Blood and body fluid precautions encouraged precautions when working with someone known or suspected to be infected with a blood-borne pathogen like HIV or hepatitis B. Now stick with me because blood-borne pathogens, we do come into contact with blood in our schools. But I'm just bringing this up because a lot of times in hospitals and other medical facilities, we're dealing with needles and other things that can puncture our skin. In 1987, the CDC encouraged the use of blood and body fluid precautions for all contact, regardless of their infection status. This extension of precautions to all persons was referred to as universal precautions. That's when it was born. Under these guidelines, bodily fluids of all persons were considered to be potentially infectious. Universal precautions specified the use of gloves and face shields and avoiding exposure of instruments after use when the potential for contact with body fluids was anticipated. For instance, a tongue depressor on these children, it's got bodily fluids on it. We use universal precautions, or we did in 1987. The importance of frequent hand washing was at the core of these recommendations. Again, back to frequent hand washing. The CDC is riddled with hand washing information, tons of cool stuff there. In 1996, the CDC established the term standard precautions. That's when standard precautions was born. This broadened the focus on prevention, applying principles to all patients, all students, all people, regardless of diagnosis or presumed infection status. These guidelines consider the risk of transmission of illness from both recognized and unrecognized sources. Standard precautions. Everything is a reservoir. Everything is the zombie, if you will. Zombies aren't just people. Zombies can be the toilet. They can be the dog. They can be the soil. Basically, what I'm trying to say is the 3 basic rules of standard precautions, and this is just simplified. There's more to it. If it's wet and it's not yours, don't touch it. Standard precautions, 1996, is the very simplest term. Standard precautions involve hand washing before and after patient-student contact, as well as the use of mask, face shields. This is what most of the staff is going to be using in your schools, most likely, masks and face shields. It is more likely that you'll be using goggles, gloves, and gowns. Of course, in your other rooms with your children with special needs, you may find the staff there using goggles, gloves, and gowns. Yet we have had a child use his spittle, or his spit rather, his oral mucosa as a weapon, and I'm sure we'll probably see a child try to spit at us, thinking that we'll be afraid and leave him alone. Once he figures that's going to be effective, we're probably going to want to pull the goggles, gloves, gowns, face masks, and shields out, because we just, regardless of COVID-19, I don't want someone else's slobber on me, to be honest with you. Standard Precautions 1996. These measures are the minimum infection prevention practice applying to all care, regardless of the healthcare setting or whether a person is known or suspected to carry a disease. Healthcare setting, the schoolhouse, or whether a person, a student, is known to or suspected to carry a disease. Standard precaution exposure. Sources of exposure in the school include the following: a coughing and sneezing student, assisting with meals and opening food items, assisting a child with a bloody or runny nose. If a student drools, oh my gracious, I've seen those children fall asleep at their desk and drool all over the place. If a student vomits, of course. You need to create a barrier between you and blood or bodily fluids using personal protective equipment, PPE, masks, gloves, disposable gowns. And we're going to talk a little bit more about that right now. Donning and doffing PPE, personal protective equipment, basically putting on and taking off the PPE. Now, what I'm going to do is teach this like the CDC teaches it, and then I'm going to teach it the way Nurse Kevin does it. Now, in regard to teaching, do it like the CDC says do it. I'm just sharing with you the way I do it because that's the way I learned 25 years ago and the way I'm going to continue to do things. But first, we're going to start with the CDC's method. Hand hygiene. Once you've got your hands clean, remember your hands are carriers of cooties, gather all of your personal protective equipment that you'll be needing. Apply the disposable gown first. Put on a mask, if not wearing one already, or change it, or if changing was necessary. Put on your goggles or your face shield if available and you think it's necessary, and then put on the gloves with the wrist part covering the cuff of the gown. So basically the gloves are going over the gown cuff. Now, taking off the PPE, we're going to back up one. This is how the CDC and how I put on PPE. This is how the CDC says you should take it off, and this is how I want you to do it. Unless you see something that I do, and then that's up to you, but this is how the CDC says take it off. Remove the outer layer of gloves. Remove the goggles or face shield if used. Remove the gown inside out. Remove the mask, and then do hand hygiene. I don't know if I like it that way. You do it this way. This is how I do it. Now, I use a little descriptive here, a little imagery, because we don't always see what's on our gowns. But I'm using this because sometimes we do, okay? And when we do, or we don't, the last thing we want to be doing is dragging our hands through a dirty gown. Do as I say, as the CDC says, but not as I do. There's my disclaimer. We'll move on. The first thing I do is I remove the gown inside out and ball it up in the gloves. It's a difficult maneuver, and you can practice. So I basically pop the strings on the back, fold the gown inside out, and roll the gown up into my gloves. The gloves come off during the gowning doffing maneuver. When I take my gown off, the gloves come off at the same time. I remove my goggles or face shield if I used it. I then take off my mask, and then I wash my hands. Now, environmental focused cleanup areas. I suggest that between each class, after the end of each day, if students leave and come back, a quick rub down of furniture, door handles, desks, countertops, paper towel pumps, floors, seats, light switches, sinks, phones, toilet flush handles, soap dispensers, and tables. This could take you all day, but the best thing that you can do is to make sure that you at least wipe them down quickly and to the best of your ability and the time that you have allotted. When to go see the nurse without delay. Now, I'm going to go through a little bit of instruction here on when you should go see the nurse right away. Don't stop at go. Don't collect your $200. Go straight to jail, right? Go see the nurse. And then we're going to talk about when we might want to consider waiting a little bit. First, when to go see the nurse without delay. Confusion or disorientation. Decreased level of consciousness. No brainer. Shortness of breath or respiratory distress. This could be from anything. Basically, maybe they're having shortness of breath secondary to their asthma. Maybe they're having anaphylaxis. All kinds of other things that are not COVID related in and of itself. Dizziness or lightheaded. Spinal cord or head injury. They fall down and they say, I can't move and it hurts to move my head. It hurts to move my legs. Don't move them. Get the nurse. Call 911. An insect sting. Now, with that being said, if you know they got an allergy to insect sting, you want to go see the nurse right away. If they don't, then you might treat it a little bit differently, but that's considering that you know that they don't have an anaphylactic possibility. If they get stung by a bug and you're not sure, go see the nurse. Vision impairment. We're not talking about the child that's having difficulty seeing the board because they were tired or because they need glasses, but they can't, all of a sudden, they can't focus on something in front of them. Something's wrong. Vomiting or diarrhea, of course. Diabetic with low blood sugar, of course. Life-threatening bleeding. We know this. Karen doesn't have to remind us of this. We know that life-threatening bleeding, go sees the nurse. Do you have any questions about this? This board, I hate. Like I said, I hate big bullet points on a lot of bullet points on one slide. We've just covered this. Do you have any questions about this slide? Now, the health office has kids with communicable illnesses. We know that. We got kids down there with cold, flu, strep. We got them down there with COVID-19. We know that sooner or later there's going to be a child in our office this year who's going to have COVID-19, an active case of COVID-19. Some situations may be best tended to in the classroom to reduce introducing the susceptible host into the chain of infection. Remember that child with COVID-19 down in my office? You send in little Susie down because she's got a splinter. Maybe not the greatest idea. We may end up in a close contact situation. Now, we got one child going home for 10, got another one going home for 14. Paper cuts, small abrasions, and pick scabs. Wash the area with soap and water. Direct to the first aid kit and apply a Band-Aid. The cure-all for everything is a Band-Aid as long as they've got a Band-Aid. Minor nosebleeds. Instruct the child to sit with his head tilted slightly forward. Have the student pinch the soft parts of his or her nose, and then after 15 minutes of constant pressure, bleeding continues, then contact the nurse for an office visit. A non-traumatic loss of a baby tooth. And if you're not sure, if the child shows up and says, hey, my tooth came out, and you're not sure if it's an adult tooth or a baby tooth, send them on down. But if it's definitely a baby tooth, non-traumatic, place the tooth in a Ziploc, have the student rinse his or her mouth out, especially if there's any blood. And if the bleeding has not resolved after 10 minutes, then contact the nurse. mild indigestion and or an upset stomach. Just not feeling very good, especially after lunch and recess. You fill that belly up with a bunch of groceries. You go outside and you run and jump, have a good time. Allow the student to use the restroom, drink some water, rest for 20 minutes, and then if things are getting worse, come see the nurse. Because they may only have to go poop. Minor injuries that can be handled in the classroom to help reduce spreading germs, chapped lips, old injuries. I hurt myself last week and it's a yellow bruise about to go away. I need to see the nurse. I'm sorry, Johnny. Go back to class. And if they're hungry. And you've seen this. Here's recess. Yippee skippy. Later, I gotta go see the nurse. I'm going to die. Minor headaches and fatigue, but the student's not acting ill in the classroom at lunch or recess. Now, somebody has told me that, I'm not a nurse. How am I supposed to know the difference? Like I said, you're a parent or you're a teacher. You know the face of illness. When in doubt, though, send them to see the nurse. Not a problem. You want to encourage snack and drinking water. Apply cool water to the face and neck with a paper towel. Rest for 20 minutes, and if things are getting worse, come see the nurse. And then during that 20 minutes, if things are rapidly becoming worse, go see the nurse. As supply allows in our school, as supplies allow, first aid kits for classrooms and front office will contain the following: Band-Aids, masks, gloves. These are your basic things that will keep everybody happy. And you got those kids with endless number of ailments. I mean, they complain about this, that, and the other. We've got those children in our schools. We love them to death. And when they don't get to see the nurse, they get like this poor child. They get upset. And eventually, they scream and holler until they are heard. And teachers be like, please help me. This child, I can't teach. Please help me. And some days you just need a break. You teachers, I understand completely. You just get this child out of my classroom for just a little bit, and that's okay. If you're not able to teach and that kid's not going to be quiet, we're going to have to do a little break, go down and see the nurse, and then we can go ahead and cure him of his woes, give him a Band-Aid, and send him on his way, maybe a peppermint. First aid supplies will be distributed to, there's Karen fussing at us school nurses, there you go, teachers, front office staff, playground folks. Replacement supplies can be obtained from the health office. Now, time for questions. And this is where we're going to conclude our presentation on infection control in schools. I hope you enjoyed it. Listen, this thing is available for download on the website. I want you to go to www.goseethenurse.com and you can download your very own copy of this PowerPoint presentation. It can be modified. Now, if you do download it, I want you to remember that the art in this particular presentation is copyright, and I don't want you to take the art and start using it on other things. It is specific to this presentation. I paid for the art. It's not that, well, I paid for it and you shouldn't be able to use it. That's not that. I paid for the right, and unfortunately, the right does not extend to the next person. You can modify the presentation, remove art, add your own, whatever you'd like to do. But please understand that the art within the presentation is copyright. Second thing, if you want to share it, please share the link. I love it when people visit goseethenurse.com. Share the link if you want to share the presentation. Let them download their own copy. I'd prefer that over you actually emailing the file. Let them go take up their bandwidth and download it directly from the website. And in the website, www.goseethenurse.com, or in the description below, you'll find the link to the download. And then enjoy. If you have any questions about this presentation, feel free to drop me a line, make a comment, and we can go from there. Hope you enjoyed it. And oh, here's Karen. We haven't talked about Karen wearing her mask. Get your mask on, Karen. Thank you. All right. That is all. All right. We'll see y'all later.